Friends, today we're back at the Parc Clinic, which took care of me in 2018, early 2018, after my back surgery that didn't go very well. So I'm going to meet with Dr. Grau Ortiz, the surgeon, who will talk to us about herniated discs. You'll see it's going to be really exceptional, so make sure to stay until the end because I know that many of you have back pain, herniated discs, and aren't really sure what to do. In this video, we're really going to answer all your questions. All right, let's get started. Let's go. Friends, today we're here with Dr. Grau Ortiz, a specialist in the spine. And in this video, we're going to talk together about herniated discs and back pain. Thank you in any case for having me here.
It's a great pleasure.
You're going to share your valuable expertise with us today to talk to my many subscribers about everything that is related to chronic back pain and its management. And of course, we're also going to talk about whether you can keep doing weight training with herniated discs. How can we avoid this? When can we postpone surgery? When does it become absolutely necessary? Introduce yourself a bit, tell us a little about your specialty.
Hi everyone, I'm Grau Ortiz. I'm an orthopedic surgeon specializing in the comprehensive treatment of various lumbar and cervical spine conditions. There are 4 of us in the group. We work in a specialized clinic located in Montpellier, and our primary specialty is effectively treating lumbar disc disease with advanced lumbar disc prostheses. We also treat many other conditions, including herniated discs, cervical hernias, lumbar scoliosis, and scoliosis in children and adolescents. We have quite a broad range, and thanks to our main area of expertise, we also care for high-level athletes, as well as athletes of all levels, to provide them with quick relief and help them return to their sport.
Okay, great. I suggest we sit down here and take a closer look at some more specific questions that I think a lot of people have, because back pain, well, I suppose it's been said for a long time, but it's kind of the ailment of the century. So I imagine you have a lot of patients who come in simply because of back pain. So we're going to talk a bit more in detail about the main questions and provide some answers. Shall we get started?
All right, let's go.
Why, Martin? Quite simply because, actually, it was just last summer, you personally reached out to me to lose a little bit of weight to get much leaner, right?
Yes, right.
How much did you lose, if I remember correctly? 7 kilos, wasn't it?
Yeah, 7 kilos. To feel significantly fitter, be able to train even better and more consistently, and truly enjoy things much more fully. It was a personal challenge, and I'm glad I did it.
And without feeling deprived, was that the case?
No, not at all.
And in the meantime, you even went on vacation for a while, I think, but you still managed to handle it.
Yes, I managed pretty well without it affecting the family too much either. In the end, I was able to keep up with the training and adapt it during the vacation. You always met my expectations each time, and when things got a bit too tough, you also truly reassured me and genuinely helped me not to feel guilty. That was truly great.
And so it was actually around that particular time that you thoughtfully sent me a few of your valued patients, specifically those individuals who were seriously considering having surgery. I'm thinking in particular of Thierry and others. You referred them to me to lose weight before their surgery. Is that something you typically do quite often regarding that particular aspect before seriously considering any surgical intervention? Do you frequently assess whether the individual person needs to lose some weight beforehand?
I've done it before. I had already done it with one of your colleagues a few years ago. It was a bit difficult to manage because it wasn't something organized, so we couldn't continue in the long term. But actually, that's something I'd really like to develop, because I think there are people who can get back on track and even avoid surgery in most cases. And I also think it's quite interesting, even after surgery, to restart it so they can get back into their sports the way they truly want to.
We might talk about that a little more in detail later on. But another reason I wanted to make this video here in this clinic today is because, as you know, it means something important to me. To put it briefly, in 2017, at the end of 2017, I had surgery, so to speak, at the Nice University Hospital. It was a herniectomy. Could you just briefly explain what a herniectomy is for people who don't know?
Yes, absolutely. A herniectomy is a technical procedure performed under interventional radiology to remove a lumbar disc herniation. When you remove a herniated disc, There are several ways to do it. It can be removed by herniectomy when the anatomy is suitable for it. It can be removed by conventional surgery with a standard scar or a minimal scar that can be as small as 2 centimeters or even less. Now it can even be removed using a camera through endoscopy. That's also an option. There are plenty of techniques. These are just different approaches, but the goal is to try to relieve sciatica, that is pain in the leg, or persistent cruralgia, which was probably your case at the time.
That's right. The reason I chose that actually was because I thought it would be quicker, allowing me to recover faster than with a more traditional operation. And especially because I kept getting stuck all the time, I was really in a lot of pain. It could take up to 2 weeks before I could recover. So I chose that procedure, except that not everything went as planned because I caught a hospital-acquired infection there and they didn't detect it right away. So I ended up staying there for more than a month and a half without knowing what was wrong with me. At first they told me I had post-operative dumping. Turns out that wasn't the case. So I ended up going urgently to the Park Clinic to get a completely different opinion. And they took care of me right away and found out what was wrong with me that very night. They did lumbar punctures on me. It lasted 45 minutes and it was awful. It was awful. It hurt a lot. I don't know if you can quickly explain what that is too.
What you haven't mentioned is that I actually remember you from that time because you were taken care of by one of my colleagues, Guillaume Geneste. It went well. And then I came by your room a few times because he must have been on vacation, or I don't remember exactly. And in fact, we had you undergo a procedure called a disc puncture. Similarly, under radiology, we biopsy a piece of the disc, which we then send for analysis to look for the bacteria responsible for spondylodiscitis, because at the time that's what we suspected. Then to go over the story, the act of performing a herniectomy. When there's a problem with postoperative pain, it's not necessarily easy to think of spondylodiscitis because it's already a very rare complication with open surgery, meaning with an incision, and it's even rarer with a herniectomy. So it's true that it's not easy to think of that. And well, the fact that you changed hospitals, maybe we were able to look at your case with fresh eyes, and that's probably what allowed us to make the diagnosis more quickly, and then the treatment followed.
It all happened pretty quickly. It's true that the care I received was really top-notch. They put me on antibiotics. Unfortunately, I had an allergic reaction to the antibiotics, but well, there was no way to know that in advance. I'm pretty prone to allergies with antibiotics, but still it allowed me to get treated. Then they put me in a hard brace, which I ended up wearing for almost more than 3 months. But it's true, I really received excellent care here at this clinic. That's why I really wanted to, well, make this video here as well. It's absolutely true that today I have brought you my x-rays that I had done approximately a year after my herniectomy and my spondylodiscitis. If you could quickly remind us what spondylodiscitis is, just briefly.
Spondylodiscitis is an infection of the disc. The disc is the shock absorber you can see here between the vertebrae. It's the slightly flexible part that, among other things, allows for mobility, and it's also where disc herniations can actually originate. In summary, when it cracks at the back, a small piece of the nucleus of the disc, the central part, gets expelled, and when it is pushed out backward, it will compress either the sciatic nerve, the root of the sciatic nerve, or the root of the femoral nerve, depending on the level.
Yeah, sure.
For you, it was at the L4, L5 level. Apparently, there was also a herniation at L5S1, but from what I see here, the procedure you had was probably at L4, L5. So that causes sciatica more on the side of the thigh, the side of the leg, and around the ankle with more or less a neurological deficit. That was something to check, but apparently that wasn't the case. And so what happened is that you developed an infection in the disc, and as you can see, it looks really, really different from the others. It's almost non-existent compared to this one, but especially compared to this one, which is normal. And above all the white you see around it is a major inflammation, and that's what was causing you such significant pain. So actually, when we see this, well, we think of spondylodiscitis. If we don't have another diagnosis, we confirm the diagnosis by doing a biopsy and analysis. So we put you on antibiotics, a brace to help with the pain, and then that's it. You're set for 3 months.
Yeah, that's right. And then it lasted a little bit longer, but well, I didn't let it get me down because, as you know, 2 years later, I got back on stage to compete, to challenge myself, and also to show that that you can come back to the highest level despite that. So there you go. And today, when you see this, where there's almost no disc left, I suppose that also explains the pain I still have today because, Well, unfortunately, people often ask me in the comments on my videos if I still have back pain. Well, yes, I'm not going to lie. I have back pain when I get up in the morning. I often have back pain when I'm in the car for more than half an hour, when I'm standing for a long time, etc. So there you go. It's pain that's pretty much constant despite everything. And well, I guess that's the reason why.
So today we didn't do any new imaging, but if we did, maybe there wouldn't be as much inflammation. However, what is certain is that there would still be disc wear, what we call discopathy. But to really know what stage it's at, you need to do an MRI like you did before, and you also need to do a CT scan, because the CT scan will show whether there is still a clearly visible space and not a spontaneous fusion of the vertebrae, which can happen in spondylodiscitis. So after that, the treatment really depends on the specific state you're in, on the precise level of pain, whether it's a daily occurrence, whether it has a strong impact on your personal, athletic, or even professional activities. And from there, well, that's when we ultimately decide whether or not to treat.
All right. So then, in my case, for example, where there's almost no disc left, is that something you also see frequently in some patients? And in those cases, is the only quote-unquote way to treat the problem and the pain actually the titanium disc prostheses that, well, you might be used to operating with?
Well, that could be an option. To be sure, though, you need to get a CT scan, that's for sure. The CT scan will allow us to see if the vertebrae aren't fused together. It will also let us see the joints behind the vertebrae. The spinal segment is like a tripod. It's the disc and two joints at the back, so we need to check if the joints at the back aren't too damaged. So once we've checked that, we can consider using a more mobile implant if there's not too much wear. If there's wear on the disc, we'll replace the disc, but we need to check if the back part is healthy. If it's healthy, we do an exam called an EOS. It's actually a large X-ray where we can see the entire spine, the balance in space, whether there are any deformities. And with that, we can decide whether or not to proceed with the disc prosthesis procedure. The only major difficulty in your case is that we know we've treated the spondylodiscitis, but we also know that with an infection around the bone and in the disc, there can be a bacterium that we call somewhat dormant.
Yes, can become active, and so...
Active post-procedure. So that's really the only hesitation we have when we have a patient who has had spondylodiscitis.
For now, I have to admit that I'm not yet psychologically ready, but maybe one day, if I really feel that it's no longer bearable, maybe I won't really have a choice but to do it. But so that's what it looks like, right? Is that it?
Yes, that's it. Actually, what's interesting is that this implant was designed within the group by the founder Thierry Marnet, who is still very active in the field and known worldwide. It was developed 30 years ago, 31 years ago to be exact.
There's much experience with this.
There's a lot of experience. The implant has evolved over the years, and today it's quite advanced. It's the most studied and most widely used implant in the world across all 5 continents by many surgeons. Actually, it's an implant that's not very well known because in the end, lumbar disc surgery isn't for a huge number of people, because for most individuals with proper training and dedicated physical therapy, we can effectively manage the pain and ultimately avoid surgery.
All right. Well, that's exactly what we'll look at in the second part. When is it absolutely necessary to have surgery? How can it be avoided? So this one is for the cervical spine, right?
Cervical, that's much more common. More implants are placed worldwide. That's an implant that has been quite successful.
So now actually these prostheses that were ultimately invented here, they're used all over the world, right?
Yeah, they're used all over the world, but actually it's only a small number of surgeons who perform these procedures.
If I'm also a bit scared of having this procedure done, it's because unlike a herniatomy or other operations, this one is more, it's done from the front actually.
Exactly, through the abs.
So that means my abs are going to be somewhat affected.
They'll be separated, but they will not be cut. So we'll carefully go through what's called the linea alba, which is located right in the very middle. We'll just move them aside, but only on one side. And then at the very end, we carefully close up the abdominal wall, meaning the strong sheath that covers the abs. We close it up, tightening it well together. We allow the necessary healing time, which must be respected. And then, in theory, especially in men, we don't have many issues with the abs.
So normally, after this procedure, you can still see your abs just like before. There's no problem or separation or anything else that could...
Yes, by the way, you know someone who has really impressive abs and with whom you sometimes train, who had this particular operation, and it truly allows him to train properly and to have a very good physique.
It's true, it's true.
Good physique.
Yes, indeed, yeah. So I wanted to ask you a few questions too. So what exactly is the most common type of pain experienced among, let's say, patients who are specifically between the ages of 30 and 50 years old? What do you see most often?
There are two types of problems we often see between 30 and 50. Disc-related pain, which you have. Actually, people who have lower back pain, more like a band across the back, a feeling of pressure that can sometimes go as far as locking up. Apparently, that's what you've already experienced.
The intense heat and also the persistent burning sensation.
Exactly. So that's more of a disc-related kind of pain. Basically, people will feel it when they go from sitting to standing. When changing positions, they'll feel pain. When they're standing around, they'll also feel that it's uncomfortable. When you stay seated for a long time, you'll feel the need to move, to get up, to change your position on the chair. These are the kinds of pains we usually see in younger people. In older people, it can be those, but it can also be joint-related pain, meaning at the back, the rear part of the tripod. The pain will be a bit different, more noticeable during movement. They will really have a different kind of pain profile. And then in addition, there are sciatic pains, just like what you experienced. In this case, people don't necessarily have lower back pain. They might, but sometimes they have nothing in the back and instead have pain in one leg or in both legs. So those are really the two conditions we most frequently see in younger patients.
So that's the most common reason for consultation, right?
For young people, yes. For lower back pain, yes.
Okay. And what about pain at night? Is that related or is it something different?
Lower back pain at night, that can happen with inflammatory disc disease like yours. They wake up at night and can also have pain when changing positions. When you sleep, you're not completely still, you move around, and sometimes at night you feel pain changing positions.
And actually, why does it seem like more and more people are experiencing significant back pain these days? Is it because of being overweight? Is it perhaps the lifestyle, the very way that we live our lives? Is it something quite specific or not necessarily so?
Maybe it's also that several years ago people paid less attention to all this.
That's true, yeah. Maybe we just talked about it less.
People would say, that's just how it is, I have back pain, it'll go away. The neighbor has back pain too and he doesn't complain about it.
It's normal.
Whereas today we feel like there are actually ways to treat it, so maybe people pay more attention. After all, we don't really know the exact origin of lower back problems with 100% certainty. We do know that there's an obvious genetic component. Now, this is just my personal opinion, but I feel like if you're not a high-level athlete, it's actually pretty hard to really damage your back. High-level athletes have injuries that regular people just don't get. So for them, there really must be a contributing factor there. I think that activity can trigger pain, but it doesn't necessarily cause an injury. That's more true for disc pain, discopathies. It's a bit less true for herniated discs, where people often do report a specific triggering event. Lifting a heavy load under poor conditions, maybe you're a bit tired, you've had a long day, you're moving house or shifting a piece of furniture, and then suddenly the pain hits right in your back, your leg, or both. It can happen. So here we do get the sense that it's more the lifestyle that triggers it, even though we also know that there are people who develop sciatica due to a disc problem, and that's that. So the two are closely linked.
So how can we tell the difference between, say, muscle pain and pain that's related to a disc? Because often I imagine that's a common reason people come in and we don't really know if it's more muscular or more disc related.
It's not always easy.
It's not easy to detect.
What we really like is working as a team, first of all. Personally, I place a lot of importance on that, on teamwork. So with my 3 partners, but also with the team of physical therapists we work with. We work with a team of physical therapists that you know well. Actually, we talked about you this morning.
Really?
Yeah, they remember you very well. And we also have contacts throughout the city and the region whom we trust and with whom we do patient assessments. It's not easy because most pains will go away on their own.
Yeah.
Actually, you have to get people to accept it, and it's not always easy to put a name to the pain you're feeling. So when we, quote unquote, have the luck to have this kind of lesion, we know where it comes from. But our biggest fear is when someone has been in pain for years and comes in with a normal MRI, meaning an MRI where all the discs look like this.
Then it's complicated to know where it's coming from.
No herniation, nothing at all on the joints. and the person feels like they're not being believed. Actually, I do believe them too, but I don't have the answer. I don't have the surgical solution, and I don't even have the answer about the origin. So here we have another very interesting resource. It's a little known profession, but it's essential. It's the physical medicine doctor. So they're very well known in rehabilitation centers, but there are also some physical medicine doctors who see patients in private practice, in the community. These are our best non-surgical allies. So when we have patients who don't require surgery or surgical follow-up, these are the professionals we turn to for their care.
Yes, because it's complicated if nothing shows up on MRIs, X-rays, and so on.
It's a stressful situation. Right away, I say that I believe you because you have no reason to come and make things up.
Yeah, that's true.
You're here because something is wrong. But then I also say frankly that I don't see any lesion. That doesn't mean there's nothing there. It means that the lesion they have just isn't detectable on the tests. And it also means that there's no surgical solution for the problem they're presenting. But that certainly doesn't mean I'm not interested in their case.
Yes.
I'm always looking for a way out for people so that they can get the best possible care and attention.
So earlier you're telling me when we talked about elite athletes that it's obviously more common for high-level athletes to get injured, in quotes, or to get a herniated disc than for an average person. Do you often have elite athletes coming to see you after an injury, or because of what, lifting weights that are too heavy, more in weight training or other sports? So who are the athletes who come to see you?
It can happen. Well, there are very diverse profiles. There are active elite athletes.
Yes. In which sports?
So we've had elite athletes from various demanding sports such as rugby, soccer, judo, and even extreme sports like BMX. And recently, we've also welcomed athletes from mixed martial arts, MMA, for the first time, an active athlete. It was a truly unique situation with an absolutely incredible person.
Really?
Yes, truly an amazing encounter. We were both stepping into the unknown a bit, but it was a situation that was mutually accepted on both sides. And there you go. We'll just have to see how far we can truly go.
So did he actually get a herniated disc during a match, during the warm-up, or during a training session?
Several. He already had surgery twice.
Okay.
He was a very young patient twice, someone who was truly sensible and understanding, so he diligently followed a good physiotherapy and reconditioning protocol. He meticulously did everything in the correct order. And despite all that, he got injured again. And at that point, the situation became unbearable. He couldn't fight anymore. He couldn't train.
So do you think it was from twisting movements? It was from movements of, how could he have done that to himself?
He probably has something intrinsic there.
So genetically, from the start, he was predisposed?
Predisposed, and then of course at 27, having already had 3 surgeries, that's not a common situation. So yes, I think that sports definitely played a major role in accelerating things, especially his particular sport. And so we decided to go with a disc prosthesis treatment for him, not knowing how he would respond to it, or if he would be able to fight again. Deep down, I'm sure, and he is even more convinced than I am that it's going to work. So
you're going to go with a disc prosthesis like that?
We've already started. It's been a few weeks now. I know he's slowly starting to train again.
Oh, so he's had the surgery?
He's had the surgery, but I know he's starting to train again, being serious and listening to his body.
Okay, how long has it been?
He had undergone the surgical procedure approximately 3 weeks ago.
After 3 weeks, he can start getting back into it?
He started slowly. He took good care of his scar. He was really serious about it. And now he's starting to do some body weight exercises again, a few squats, a bit of mobility work.
And actually, after this kind of procedure, how long do you think it really takes before you can get back to 100%, so to speak?
Well, it depends on the sport. If I have someone reasonable in front of me, I like people to take part in their own recovery and also in their program. I actually allow them to resume activity quite quickly, like free weight exercises or cardio, as long as they are not lifting heavy loads, especially at first to protect the abs. I really do allow it quite quickly. My biggest limitation at first is the healing of the skin. We want people to have the least visible scar possible so they can really forget about this issue. At the beginning, we make sure the scar is of good quality and properly monitored. But quite quickly, we can allow a return to some cardio exercise, weight training with weights, honestly, pretty quickly and progressively. It also depends on your baseline level in the end.
Yeah, exactly, that's right. Speaking of which, it's true that I get quite a few people reaching out to me because they've seen everything I went through with my hernia, etc. And they too have herniated discs. And often actually, well, at their first appointment with a regular doctor, they're told, well, you have to stop everything, you have to quit weight training, you have to stop working out. Basically, you shouldn't do anything anymore. And it's true that every time I hear that, I'm a bit, well, a bit shocked, because I know very well that in most cases it actually has the opposite effect of what you'd want.
Plus, that's not even the core message from health authorities, who actually strongly encourage people to stay active and engaged. What I'm explaining is that when you get injured, when a particular movement hurts, perhaps for the time it takes to fully heal, you should ease off or carefully adapt that specific movement. But I never suggest stopping altogether. I always suggest adapting. That is, if you finish a session feeling worse than before, maybe that session wasn't right for you, but that doesn't mean you couldn't have done a session at all. So I rather suggest that people adapt. For people who don't know themselves well, I suggest they get help. And for people, well, if I had a patient like you who knows themselves perfectly, I know very well that you'd be able to adapt your session to keep training.
That's actually what I do now for my own training, because obviously I don't do squats, deadlifts, or bent over rows. I try to do all the exercises, in fact, with support, where my torso is supported. But of course, I still keep training 6 days out of 7. These days, I truly think that with all the machines we have in gyms and elsewhere, there's always a way to find something so you can consistently keep being active and keep getting stronger. That's really the most important thing, I believe.
What worries me when I hear people talk is when they say, I need to hold myself back because otherwise I'll go all out again. But that's never how it works in any sport. You don't do that. Actually, you always start again from the basics and gradually increase the intensity. And that's true in every sport. So it's true for sports, and it's also true in the medical field in the end. If you go all out right away, there's a good chance you'll end up back at square one pretty quickly. So that's it. We don't hold people back, but we do temper them so they can get back into it gradually and regain their previous level, or even go beyond it. Having surgery doesn't transform you. You don't become a superhero just because you had an operation.
Exactly.
The idea is to become the person you were before. And once you truly become the person you were, then you earn your well-deserved after. That's it.
You have to take your time. It's quite clear that, well, once I had officially left the clinic here at Parc, I still had a good few weeks, even several months, with the brace and all that. But even with the brace, I still had to use a walker, you know. Actually, I was doing dips on my walker, push-ups, and then I had attached resistance bands. I was using the bands, and until I could walk with the brace, I went to the gym, did a few machines, but with very light weights, just to get the feeling back. And psychologically as well, the fact of getting back, of returning to the gym, it was incredible. So for me, who had been, well, you know, when you've been training for over 25 years and then overnight, you find yourself in a hospital bed for months, unable to move. I don't know if you remember, but sometimes I would amuse myself, though I don't recommend this to anyone, by doing pull-ups on the hospital bed. You really shouldn't do that. It was just for fun. But anyway, all that to say that you really have to take things very gradually. And then, you know, when you know yourself, it's obviously much easier. But there you go. So what are your thoughts and opinions about exercises like squats, deadlifts, and other similar movements, those kinds of things that can potentially, well, put significant compression on the spinal discs? Is that something that should be actively avoided? Or is it something that an average healthy person without any underlying medical issues or pre-existing conditions can safely and confidently do without encountering any significant problems at all?
For me, it's not an exercise to avoid as long as it's performed correctly. If you're not able to do it properly, well, don't do it. If you can do it properly, or if someone is there to help you do it properly, I don't see it as an exercise to ban. After that, as always, it's about gradually increasing the load. Someone who lifts 50 kilos and someone who lifts 100 obviously won't start back with the same weights. Someone who's used to it and someone who isn't won't start back with the same weights either. But it's not an exercise I would forbid. You, for example, I think you stopped doing squats, at least the classic squat with a bar, maybe because it was uncomfortable at first, or...
Yes, that's part of it. And then there's also the fact that, well, when you look at my x-ray, you can see that I barely have any discs left here. And as soon as I do exercises where I have weights on my shoulders, I immediately feel pain. At least sometimes I don't feel it the same day, but the next day I really feel that it's pulling and that it's probably inflamed or something like that. So now I avoid that kind of exercise, but I try to do exercises where I feel safer, more slowly, without... Well, yes, I do add a little bit of weight too, because, you know, when you train, you still need a certain level of intensity. But no, here I was talking about regular people who don't necessarily have back problems. I know there are people who are afraid to do squats or deadlifts because they're worried about triggering a hernia, even though they don't actually have any issues to begin with. So that's mainly it. There's no reason to be afraid of doing those kinds of exercises.